Welcome to BrainTalk, a podcast from Project BrainStorm about the bipolar spectrum. Your hosts are Dr. Jim Phelps, a psychiatrist and author of several groundbreaking books about bipolar, and Sara Schley, co-creator of BrainStorm the Film, a documentary inspired by her memoir, BrainStorm, From Broken to Blessed on the Bipolar Spectrum. Each episode of BrainTalk will interview new experts about their research and expertise within bipolar. Let's work together to save lives, end the stigma, and create healing for everyone on the bipolar spectrum and those who love them.
Good morning, Jim. How are you?
Good morning, Sara Schley. I am well, thank you.
Good. Yeah. Well, we don't know when this is going to air, but right now the sap is flowing from the trees. And if you could see this, it's crystal clear water that I put the tap up to the tree, drink it.
You know, if you actually
It's a miracle.
if you had a product for sale there, you would be doing a gross self-promotion there.
It's amazing. Yeah. The maple is really something because it's just a hint of sweet and it's so good. And it only happens a couple weeks a year and people say, can you ship me some? And the answer is no. But so today we're welcoming Dr. Nancy Byatt, and I'm really excited to talk with her. Again, we have the privilege of filming her, recording her for the film BrainStorm. Do you know anything about Nancy's work?
As it happens, she had been at the University of Washington where they established that system of care called collaborative care, the whole model of consulting, psychiatrist consulting in primary care, which we'll hear more about from her. But she was there kind of at the center of where this idea first came from. And our group actually used that same model to build a collaborative care program in our hospital and primary care system.
Wow, that's amazing to hear those roots. Okay, well, let's welcome her to the show. Welcome to Brain Talk, Dr. Nancy Byatt. Good morning.
Morning.
So nice to have you with us. We're really thrilled.
Good to be here with you both.
So let's just dive in. Can you just tell us a little bit about your work, what kind of a doctor, psychiatrist you are, and where you are on the planet Earth right now?
Sure. Well, I'm in Massachusetts. I'm at UMass Chan Medical School, and I direct a center called Lifeline for Families at UMass Chan Medical School. And I'm a psychiatrist. I'm focused on working with pregnant and postpartum individuals, so we often refer to as a perinatal psychiatrist. What brings me to this work is really my own lived experience and the experience of, as a psychiatrist, being really frustrated, actually, working with pregnant and postpartum individuals, because I always found it really challenging to get them the care that they needed and deserves. And that's sort of what brings me to be here today and really has been the driver for a lot of the work that I've been doing.
Yeah, and thank you for that work. It's, as Sara was pointing out to me in a previous episode of this podcast, it is actually half of the people with bipolar disorder for whom this territory that you work in is a relevant thing, So we've been missing half the population, basically.
All of us women. Right, exactly. Do you want to share a little bit about your lived experience that you said brought you to the work, if you want?
Sure. Yeah, I'm happy to. So when I grew up acutely aware of the importance of sort of maternal mental health, because I saw my mom struggle with disrupted bonding and challenging relationship with her own mother. So when my mom was a baby, she was born at the end of World War II during a very sort of snowy winter in London. And when she was born, my grandmother was very ill. Looking back, it's pretty clear that was likely bipolar disorder. And my grandmother couldn't apparently tolerate my mother's presence. So my parents went to their family physician and they were asked what they should do. Their family physician told them to put an ad in the paper for someone to take my mom.
Wow.
So they did that. They put an ad in the paper. 2 different families responded. My parents, I know your sort of jaws are dropping. I know, I can see your jaws dropping. Like, it's pretty wild, right? And they chose the family actually that was sort of in a lower socioeconomic situation because they thought it would be more a more real experience by mom, apparently. So my mom was separated from her mom for 6 months during her first year of life, according to the doctor's orders, right? Wow. And so when my mom went back, and they had absolutely no contact. They lived in the same town as my mom. Her biological family, 0 contact during her first year of life. My mom went back to her biological family when she was about 13 months old. And from what I can tell, my grandmother remained profoundly depressed throughout most of my mother's upbringing. So there was sort of that piece. And, I've sort of watched my mom really work through healing herself from that experience, and then also working really hard to sort of mitigate or decrease, like passing along that trauma to me. And despite my mother's really, hard work doing that, I sort of, and then how this has impacted me was I experienced sort of my own trauma in other ways, not necessarily related to my mother's illness, but related to other things. And I haven't experienced bipolar disorder, but I've experienced, anxiety and things like that. Most of that for me has been trauma driven, but it's sort of a lot of this transgenerational trauma started with sort of my grandmother's untreated bipolar disorder, or the treatment that she was recommended was clearly not helpful and created this sort of cycle that like has impacted me, my kids, and I've worked hard to break the cycle with my own children. Not completely been able to do it, but I've, it's sort of this cycle that we're all working to try to have be less so with each generation.
Wow.
So sorry. Right. Both of us are jaw dropped. Like that's not something you would prescribe, right, Jim, to have.
Oh my gosh.
So you come by it honestly. And sometimes I have a teacher that's coming to my mind who said, from your wound to your passion to your gift.
Totally.
Right. So now you're inspired, and tell us what happened. You went through med school and became a psychiatrist. And then you said that you were seeing that pregnant women or pregnant people, I'm not sure the right term right now, were in this political climate. But at any point, people who are pregnant were not getting the care they needed. So just tell us a little bit more what you were seeing there.
Yeah. So then, so I always wanted to be a psychiatrist. I think growing up, seeing all this sort of, these challenges around me, I wanted to be a psychiatrist since I was like 12 years old and was reading a lot of books. And then I did general adult psychiatry residency. And then I did a subspecialty in sort of the interface of psychiatry and medicine. And during that fellowship, I then further specialized in working with pregnant and postpartum individuals. So I was a psychiatrist seeing patients that were pregnant or postpartum. And time again, people would come in and they would be telling me about how hard it was to come to get to see me, or about how, they had no idea that they had depression or bipolar disorder or anxiety. The other thing that struck me was that none of their professionals they were working with are asking them about their mental health or their mood. And the profound impact it was having on them and their children was very clear. So I saw this huge unmet need. And so I kind of come full circle to be a perinatal psychiatrist myself, and was seeing this huge unmet need clinically that was different than what my mother experienced in the late 1940s, but there was still a lot of unmet need that was manifesting in a different way. And that's what sort of motivated the work that I've been doing.
Mm-hmm. Wow. Yeah. So, I mean, I can just keep going on this line of questioning because, of course, as a woman, I would go to my OBGYN on an annual basis. And then I had twins, and, I saw my wonderful OBGYN at that period quite frequently, but they're not trained, right? They don't know what the right questions to ask, all right? Or that if they did, is it sort of like, I mean, you and I have had some conversations before, a little bit like head in the sand, because they don't really want to know because they weren't trained and they don't know what to do, right? So.
Right.
Absolutely. Absolutely. And that's what we saw.
I had the same experience of primary care wanting to refer people to me, and our whole system was full, and we were waiting list, and I thought this is just untenable, and that's what led me into working so closely with primary care through for the last 20 years basically, and ultimately to that system called collaborative care, which I know you have studied, and then you created yet another variation there in Massachusetts. So ultimately, I didn't want to interrupt, but ultimately, I'm going to ask you to describe for us collaborative care and the McPath for Mom program, and how those work, because they are the solution that you helped engineer to the problem that you are describing.
Yeah, exactly. Well, that's exactly what I saw. It would take months for people to get in to see me. And I thought, what I'm doing is not that hard. We can train other people to do this. That was exactly what I experienced as well, where people would take forever to get in to see me. It was sort of like a bottleneck where there was too many patients and I just couldn't see them all. And I thought there's got to be a better way. Right. So what we actually did was we talked to patients with lived experience, and we talked to, perinatal care professionals like OBGYNs and midwives and so forth, and nurses. What we heard from perinatal individuals was that their OBs didn't know what to do. They knew they wanted to help, but they didn't know what to do. Mm-hmm. And we heard from the OBs that they really wanted to help. They knew this was important. They did not know how, and they needed a lifeline. They needed some consultation. They needed some expertise. It would be like if I was all of a sudden treating high blood pressure. I would need I would need some guidance. I wouldn't be able to just do that. I might be a physician, but I wouldn't be able to just treat high blood pressure. So that led us to develop the model. The program in Massachusetts is called MCPAP for Moms, which is the acronym is the Massachusetts Child Psychiatry Access Program for Moms. Nationally, they tend to be referred to as perinatal psychiatry access programs. We had a program in Massachusetts called MCPAP, Massachusetts Child Psychiatry Access Program. That program was developed to really address similar challenges with kids. So kids and families were seeing their pediatric clinicians. They didn't know what to do, similar access challenges. MCPAP was developed to provide consultation for kids for pediatric clinicians to be able to get consultation about how to treat the kids. So we already had that model in Massachusetts. So we thought, after we talked to people and did focus groups from both, women and the professionals serving them, we thought, well, can't we expand this model for perinatal individuals and help OBs do this? And that's what we did. We did that through sort of research. We tested it. And then the long story short is it got put in as a line item in the state budget, and it got funded statewide very shortly after we sort of even conceptualized the model.
Wow. And wait, let's ring the bell. It got put as a line item in the state budget?
We really advocated for funding for the statewide program, and a lot of people, and a huge driver of this was people's lived experience. I often refer to it as the light in our wounds that drove this movement. And it was really people with lived experience telling their stories. We had Postpartum Depression Awareness Day. We had a PPD, Postpartum Depression Commission. It was really all of those things together, and a lot of advocacy by the legislature as well that got this funded statewide just really very quickly after we beta tested it. And it was because there was a huge need, and the state recognized that.
I see. Wow. Yeah. So you're downplaying your accomplishment a little bit, I think.
That's phenomenal. Yeah. I'm sitting here going, proud to be from Massachusetts, but thank you so much. Nancy's incredible. And I imagine the lived experience stories, like when you say 3-4 months, they're not getting care, 5-6 months. And, and somebody think, oh, my life, 6 months, not that much. That's how often I go to the dentist. No, 6 months when you're depressed with a baby is
absolutely
a disaster, right? For the child, for the family, for everybody.
Yeah.
It's not acceptable. Exactly. Yeah, it's absolutely unacceptable. And I think that is something that people hear. Our program has been in place now for a little bit over 10 years. And addressing mental health wasn't then seen as part of OB care, right? Now it really is. The most recent American College of OBGYN and the related guidelines really do recommend that obstetric, settings are screening, assessing, and treating mood and anxiety disorders, including screening for bipolar disorder. And that's been a huge shift that's sort of come along. When we started doing this, it was very in its infancy. So we're very pleased to see that the professional organizations are now recommending this, and that's made a huge difference.
Wow. Yeah, great. Another addition to your accomplishment, frankly. So you're serving a lot of women indirectly beyond those whom you've been able to consult for directly. Congratulations.
So I'll give a little tidbit, and then you can help unpack how did this possibly happen.
Yeah.
So, again, I've been working on Blessed of the same doctor for 30 years. Her name's Dr. Linda Polanski.
Yes.
Right? And I've written a book about bipolar, and I know a little bit because I've studied with Jim.
Yeah, I know Linda. She's wonderful. Yeah.
She's awesome, right? And I've studied with the Jim a little. So after my annual checkup, which everything's fine, so I say to her, do you screen for depression? And she said, yeah, we do. And she said, and we screen for bipolar too, because I don't want to give antidepressants and trigger mania. And I was like, what? The lights go off in my head. How does an OBGYN know this? That's amazing, because that's PhD level, right? And she described that she was in your program, right? So can you share a little bit more, this satellite obstetrics practice in the middle of nowhere, Western Mass? How did that whole happen that I got to Linda's office and she had the right answer?
So MCPAP for Moms is and there's now 30 programs like this across the country. So just to add that, it quickly got disseminated, and we now have, in addition to ours in Massachusetts, 29. There's 30 total. It quickly spread. It's federally funded, which is amazing. Beyond what I ever imagined would happen. The way those programs work is they're statewide, right? So if an OB, they provide training, consultation over the phone, also face-to-face, one-time consultation with a psychiatrist, and then resource and referral. And that was how MCPAP for Moms was when we first started it, and really still maintains that way. The benefit of that is we cover the entire state. Any, person serving a pregnant, any professional serving a pregnant or postpartum individual can call us and we'll help them respond to the patient's concerns, right? The challenge with that is we're not really working with the practice to do like workflow integration, like what collaborative care does, for example. We're not sort of like, we're there, we're kind of reacting to a positive screen or to a concern. So what we did, and I'll say what we did with Linda's practice, and we did this with several practices across Massachusetts, is we basically work with the practice. We do an assessment. We look at, are you currently meeting the recommended standards of care, which they rarely ever are, hence why we need the study. And then we work with them to integrate. We sort of provide the scaffolding, and in a way it's like quality improvement, for them to integrate screening for depression, anxiety, bipolar disorder. Because what we don't want is there's data that, many people who screen positive for depression may have undiagnosed bipolar disorder. And so we don't want them to be starting an antidepressant, knee-jerking to an antidepressant, and not screening for bipolar disorder. So as part of that workflow integration, we have them screen for bipolar disorder in the beginning of, like at the initial OB visit, for example, at the first visit. So that way the whole pregnancy, if they ever screen positive, then they can say, oh, let me check if they screen positive for bipolar disorder, and then they can adjust the treatment in response. And if they did screen positive, they can call us and we'll help them manage that. And a ton of the calls we get at MCPAP for Moms are about bipolar disorder.
Mm. When you say a ton, can you put a rough number on that?
I don't have an exact number. Actually, it's a good question. I don't have an exact number, but what I can say is that, when we first started our program, we were very focused on depression because at the time, this was very new. Even addressing any mental health was new. And people would say, oh, you're going to get less calls about depression because they're going to know how to do it. They're not going to need to call you. And we said, we think they're going to call us about more complicated illness. And that's what we see. The vast majority of calls I get now are sort of differentiating between PTSD, sort of mood dysregulation that's more trauma driven versus like bipolar disorder. Yeah. And so a lot of the one-time consultations we're doing are for that. When we started MCPAP for Moms, we just didn't imagine that they would be doing that they would be actually treating bipolar disorder. And of course, should someone with bipolar disorder have access to a psychiatrist? Absolutely. Everybody should have access to a psychiatrist, particularly bipolar disorder, because it can be, more complex to treat, right? However, what we find is that if someone has public health insurance, it may take that 6 months you talked about earlier, Sarah, not good enough. So What we do is we sort of help them manage until we can get them in longer term. And so it really sort of helps with getting them quickly. And we can see people for one-time consult within a couple of weeks, which is very quick, sometimes even within a week. And that's what people who have, a mood disorder during pregnancy and postpartum, they need to be seen that quickly.
That's right.
Yeah.
Yeah, I know, it's stunning.
Very similar, Nancy, to our experience in Oregon, where we started a collaborative care program. And I thought the screening tool that had been used in research was under detecting bipolarity. So we added the screening tool that actually Sara used when her diagnosis was made. And we came up with a figure of something around 30% of people whom we were asked to consult on screened enough positive for bipolarity that's what their recommendation was in terms of treatment options.
Yep.
So you're nodding your head at 30%. Sounds like you think, yeah, maybe ballpark, you're in the same territory.
Yeah, I would say that. So the data that we have, not from our group, but from others, is that of individuals who screen positive for like postpartum depression, for example, up to 1 in 5 may have undiagnosed bipolar disorder. So that's pretty significant. And we did a review. We looked at all the scientific literature, and we found that the rates of prevalence of one mood episode in pregnancy or postpartum is 2.6%. And what we found was that among people with no history of psychiatric illness, the prevalence of a mood episode was significantly, of like a bipolar spectrum mood episode, like hypomanic, hypomania, was significantly higher than we would expect, like outside the perinatal time period. So there's definitely data to suggest that the pregnancy and postpartum period are a time of increased risk for bipolar spectrum illness. Right. And as we know, I'm sure you've heard this from other experts, many people don't go on to have chronic illness if they have the onset during that time period, right? That some do, but some won't. And that's different than if they have the onset outside that time period.
Yeah.
So there's so many things to unpack from what you just shared, right, Jim? Which direction are we going? It's awesome.
I do just want to say, I saw that paper of yours, 18%. That's the 1 in 5 figure. That was using that same screening tool that was used that made me think this is under detecting.
Yes, absolutely.
All right. So you're okay with that 18% being probably an under detection?
I do believe that overall bipolar disorder is underdetected, and I believe it's absolutely underdetected in the perinatal time period.
Mm-hmm.
And I love that Linda Polansky is like, oh, I got to screen for bipolar disorder. And that's really something that we've really been trying to work on, because obviously if you treat bipolar disorder as if it's unipolar depression, people aren't going to get better. And I think that probably happens, we're working on it. It still happens more often than it should.
Yeah.
So just to like sort of big picture here, it's like a good chunk, whether it's 20 or 30%, a lot of women who have postpartum depression are bipolar, have a bipolar depression. Prior to McPap, these OBGYNs were not trained to screen for that. Now they're screening for it, which is amazing. Probably because they can call you. I call you Mission Control, like Mission Central. They know that they can call Dr. Nancy Byatt's shop.
Yeah.
And if it's a positive screen, they get advice on what to do. And so they're not scared to do it, right? And they can do it. It's not that hard, right, Jim?
In fact, yeah, you can imagine. Wait a minute, this is a great idea. Why don't we do this like for all primary care, not just perinatal?
There absolutely is opportunities for that. And some states do that. Like Colorado actually has a program for primary care. So some states are starting to do this model for primary care, because there's a similar challenge in primary care where primary care are probably seeing tons of bipolar disorder and not necessarily screening. So kind of, I know, Joe, you mentioned earlier, Sarah, really like doing, the collaborative care specifically bipolar disorder is really important. And what we're doing is it's sort of a lighter version of that, because we don't have a care. The biggest difference is we don't have a care manager, like a full-time care manager.
Right.
Mm-hmm.
Right.
Yeah. But wouldn't that be amazing? Because we know that, most 80 to 90% of antidepressants are written by primary care.
Exactly.
With no training in psychiatry. And then our research, I don't have a lab, but what we've learned from the film, there's lots of debate, but like up to 1 in 3 of those people actually have a bipolar depression.
Absolutely.
Getting the wrong meds and getting them worse, which is my lived experience. So I always love, Nancy, if your model, if that collaborative care could be spread to all primary care. And I am remiss, because we never define collaborative care, and I can hear my producer in my back ear going, you didn't tell them what collaborative care is. So can we go back, you guys, because that's something you both have a lot of.
Yeah, sure. Jim, you want to define collaborative care?
What does it mean?
Collaborative care, a system developed at the University of Washington, places a mental health specialist, a person who is particularly responsible for managing mental health problems, in a primary care office. That person does a scripted interview to gather the data that would be routine in a psychiatric interview, and then prepares it, and in some models presents it to a psychiatrist, a remote psychiatrist. In other models, may manage the patient with the primary care provider until it's clear that, we need a psychiatric input on this one, and then alerts the available psychiatrist to come in and help. So the core ingredient is a person who's in the clinic, who's responsible for managing mental health issues, to whom the primary care providers can refer that very day when the patient comes in. And then they're responsible for follow-up to see that things are actually improving as they would hope that they are.
Mm-hmm. Yeah, and I would say what we do differs a bit from that is we don't have that sort of full-time care manager, and we're really working with the OB setting, the obstetric setting, to basically utilize their existing resources. And then when they need consultation, we create a workflow such that they call the statewide program. We wanted to sort of create an alternative model that could be kind of implemented more quickly without sort of as much cost. And people can have collaborative care in addition to those things, right? So they can kind of be complementary to each other. And because I do think collaborative care is more intense than what we do.
Right.
Yeah.
And, the beauty, collaborative care is a beautiful system, but it's been very hard to disseminate it across the country.
Exactly.
Your model has made it across the country to the tune of 30 states actually having implemented it. That's astounding.
30 out of 50 last time we counted.
Yeah, 30 out of 50.
As long as we're not getting Canada, I'm not sure.
No, there's one in Canada. Ottawa has a program. Ottawa. We do have one in Ottawa.
So, and that represents what percentage of the pregnancies out there? Like that have access to
a little bit over. So there's, it's a little over 70. It has the potential to cover just over 70% of the births in the United States.
Incredible, right? It's phenomenal.
The potential. Yeah. And the reason I say potential is one of the challenges is as I mentioned earlier, the OBs need to call. I think there's a fantasy you build it, they will come. And I think that, one of the challenges is engaging the, clinicians to call the program and to get them on board and to kind of do that. That's one of the biggest challenges we see with these programs. And so that's sort of a work in progress. Right. But like when you think about the coverage, that's how much they cover.
Phenomenal. Yeah. Right.
And in part, the challenge, like the hesitation would be, oh, you're going to ask me to do some things that I don't know how to do.
So absolutely.
Part of what you have been working on is to give them the confidence that you can do this.
Absolutely.
And once they can, then if all you have is a hammer, everything looks like a nail. When you have expanded their skill set, now things become visible that were invisible before.
Yeah, absolutely. And that's what we see with bipolar disorder specifically, that like once they get treating depression and they're screening a lot, they're like, oh goodness, I'm worried about this. And they'll uncover a history, then they'll call us and we'll help them do that, which is beyond what we thought, because they're really able to do that in a way that build their capacity more than we might have imagined. But it was it happened over time, right? That they got comfortable with depression and then anxiety and then bipolar disorder.
And they're highly motivated though, right? The OB-GYNs. I remember we did interview Dr. Melissa Sherman, who was part of your system for the film. And she was like, my job is to care for my patients, including after this baby's born. And I want to keep them out of the homeless shelter, Right. So she was I'm sure like many, like Dr. Polonsky, highly motivated,
right?
Which is awesome. So if you, because we had a caller in earlier in the year, who she was calling her daughter had severe, so the daughter had just given birth and the daughter was severely depressed. They didn't know what the heck to do. Mm-hmm. So if you are yourself experiencing postpartum depression, or you're the mother of a child who's given birth, somebody who's a spouse of, what do you do? Like, how do you get help? Mm-hmm. Do you go to your OB-GYN and say, hey, this resource is there? If somebody's listening right now to you, what would you advise them?
So one thing would be talking to like a, OB professional. And if it's postpartum, say they're 8 months postpartum and they may be not seeing that professional, going to their primary care physician. Because as we said, most depression is not necessarily treated by psychiatry, right? It's primary care and now a lot of times OB. I would say the other piece is talking with family and friends and like letting them know, because sometimes for the individual, it can be really hard to make that first step, and family members can help with that, or support systems, whatever natural support somebody has. And I would say the other thing is not everybody has those supports, right? Really, I've seen many individuals who feel really isolated, particularly if they're experiencing depression or anxiety or any mood disorder. And so the other piece is there are some, free, publicly available programs. So there's a maternal mental health hotline that is available. It's available 24 hours a day, 7 days a week. That's federally funded. And there's also Postpartum Support International has a wonderful warm line that's also available. And with both of these, the hotline's available all the time in English and Spanish. And then the warm line is available to link with resources in the community and so forth. So I could keep going on, but I think those are three.
Oh, that's great. The
PSI community, Postpartum Support International, is a wonderful community that has a lot of free support groups and so forth. They're a wonderful resource.
That's amazing. And good to know that some of those things are available nationally.
Yes.
Because, you may not be aware, there in Massachusetts, y'all are ahead of us.
I am aware.
In much of the rest of the country, and including in terms of access. Out here in Oregon, it's hard enough to get to your primary care provider. Right. And it's almost impossible to get straight to a mental health specialist, right, including even the good psychotherapists, as you're pointing out. There's a bottleneck.
Absolutely.
As well.
I'm highly aware of that.
Okay, good.
And we have a lot of perinatal psychiatrists in Massachusetts, and it's still not good enough. But I wholly recognize we do have more access than maybe perhaps the whole U.S.
But I would say too, something I've advocated for in other settings is like postpartum mom. The stigma still is you're supposed to be all happy and bliss, and it's the greatest thing that ever happened. So a lot of people aren't going to say anything, because they're going to feel shame about feeling lousy. So I would say to the support team, spouses, parents, friends, whatever, you have to reach in and you have to advocate for that person.
Absolutely.
And you got to make the phone calls. You got to pick up the phone and call, postpartum MAMH hotline, get the phone number, whatever.
Yep.
Because they're going to be overwhelmed to even take that first step, right?
I do agree with you that there can be a lot of sort of people can feel, there's this ridiculous myth that, we're supposed to be happy that somehow still persists. And it's completely not true. We actually know now that mental health and substance use disorders combined are the leading cause of maternal death in the United States. 23% of maternal deaths are due to mental health and substance use disorders. The most important thing someone can do for themselves and for their baby is to get the treatment they need and deserve. It's the best possible thing they can do. I actually think that doing that is a sign of someone being brave and of strength. It requires strength to take care of yourself and get that treatment. I think the sort of myth that it shows vulnerability, I think is the opposite. I think it actually shows strength to be vulnerable. And so I think it's sort of like turning that on its head, because that is how we develop strength, is to sort of come through our vulnerabilities, right? And so I think that's like a really important piece. And pregnancy and postpartum is a time when those vulnerabilities come up for all of us, because there's this concept of the ghost in the nursery where, whatever happened to us when we were kids, it's going to come up when we have our own baby. And that can affect our mood and our regulation and so forth.
Wow. And so it goes on.
Yeah.
Yes.
Wow. Yeah. Thank you for that. It's important.
Indeed. I'm finding myself not entirely at a loss for words. That basically never happens. But that was such an eloquent statement of the need and the solution.
Yeah, you're changing worlds,
Yeah.
I mean, my mom was postpartum with me, right? I only found out after the fact, and I know she never told a soul. No one ever knew. No, not her parents, not her husband, my dad, not anybody, right? And they just suffered. And then,
Absolutely. Well, it's funny because I'll just share this with you that recently I was at I had my annual visit with my PCP, and I actually filled out the GAD-7, which is a screen for generalized anxiety. And I know the screen because we implement it in OB practices. I'm filling out the screen and I'm like, I'm screening positive on this. Wow. And I've never been on a medication before. And then I had my PCP, the bunch of other things happening. And I'm like, oh my God, like I could tell you that I'm about to be 50, right? I'm 49. I just turned 49 actually last week. And it has taken me my whole life to realize that I have an anxiety disorder. And part of what really clinched it was scoring positive on the GAD-7.
Wow.
And now I'm like on an antidepressant. I got to tell you, I feel a lot better. And you know what? Like I have spent my career helping other settings do this, and I'm just figuring this out. So I think it speaks to how important it is that we do this screening, right? Because like, if I'm not figuring it out, I don't know who is, like.
I'm glad you're feeling better.
Yes, thank you.
That's really good. Good for you. Jim, we have been so privileged to have you, Nancy, Dr. Nancy Byatt on BrainTalk. With everything that you've shared, and there's been so much inspiration, is there like any closing message you have for us or message of hope for pregnant people or postpartum people and their loved ones who might be listening?
Yeah, thank you. It's been a pleasure to be here and pleasure to talk with you both today. The feeling of hope, I would say, is that I have been really moved by the community that has gathered around addressing perinatal mood and anxiety disorders. Like it's truly amazing. There's the community-based work, there's the professionals, and I have seen this sort of really gather huge momentum over the past 10 years. Despite what's sort of going on in the world, that movement is continuing. And I think there's always things that we can be doing to move that forward. And I think a lot of what drives that is the light within people's wounds that are really driving that movement forward. And I think that I know that our community is really, really strong. And I think, and I know that no matter what's happening, that community will continue to stay strong and keep moving this forward.
Beautiful.
Yeah.
Thank you so much. You stay strong, stay healthy. We need you. And take good care. Thanks for coming, Nancy.
Okay, you're welcome. Good to be here.
Thank you so much, Nancy. Well, we've done it again. What a privilege to have someone like that. And to share the messages as she does. That was, really exciting.
Well, it's awesome to hear that the movement is still moving. In 10 years to go from 0 to 70% of the country, there's hope, right? And it's dramatic impact of, on people's lives, what she's doing. So that's really cool. Yeah. Great to have Nancy here. My people from Massachusetts, Jim. You know I'm a chauvinist. More of Red Sox Nation to be proud of.
Right. We're not exactly right on your heels, but we're not too far behind.
Yeah, no, it's great. I'm thrilled that it's spread, and that she has access. Most practices in the state, and it sounds like in the country, have access to this kind of help. So, amen.
Yes.
All right, we'll see you soon.
Good.
Thank you for joining us on BrainTalk, your bipolar spectrum podcast. BrainTalk is a program of BrainStorm, a multi-platform project about the bipolar spectrum, which also includes Sara Schley's memoir and a full-length documentary. We aim to save lives, crush stigma, and maximize healing for all people living with bipolar and those who love them. For more information, bipolar resources, and podcast episodes, head to brainstormthefilm.com.